improving the perioperative care of patients with medical complexity undergoing surgery. So we've used cross-functional maps, which you are all familiar with, to understand like what's the process logic, and we found that there are very few standardized steps and very many stakeholders involved. And so we decided to look into the process, into more granularity, to understand a little bit more about this non-linear structure between process activities and how they are triggered and what happens in between. So we used another method called the functional resonance and analysis method. So this method enabled us to understand this nonlinear structure between processes and gave us more insights and more validity to look into different safety approaches. Safety 1 through the application of a failure modes and effects analysis, and safety 2 through the application of a contrast analysis. And by the way, I have a talk at 4 p.m. in this room. If you'd like to know more about this project and those methods, feel free to attend. The failure modes and effect analysis revealed that the last-minute workups that happen in the preoperative phase, coupled with the surgery cancellations and the unaligned family and provider expectations of the specific type of surgery that we addressed, really were the biggest failure modes and caused like the most serious effects in the postoperative phase. And the causes were mainly from uncoordinated preoperative period and communication gaps between providers and untimely decisions. So we said like, okay, let's now look at, we know that the process is likely to fail in a lot of instances, but what makes a process succeeds? Like, what are the success modes and effects analysis? So we did something called a contrast analysis, where we evaluate the differences between a case that went terribly bad and a case that went really well and unexpectedly. So we found that the key idea was, at first, in the current state, the proactiveness of the family in the perioperative continuum really improved system resiliency and made the process work well. So we're going to focus on family engagement as part of our design strategy. This problem is all about patients and children can't stand for their own decisions. So family is the key here, and working with family, like families have different expectations of their child's surgeries. They have different levels of education. So involving family in our design was like really value adding. First of all, we have been bringing education to enable families to learn more about what their children are going through by building a decision guide based on our entire understanding of the perioperative continuum. And this has helped close communication loops between providers by putting more awareness into the family and letting them sometimes take actions into their own hands. And obviously this has facilitated the retrieval and review of medical records, because at Boston Children's Hospital, the children that come to undergo surgery come from everywhere, from all states and from abroad. And sometimes retrieval of medical records is not that easy. So this has really been a huge driver. So patient engagement can happen at different levels in organizations. It can happen at the level of direct care, of organizational design and governance, and policy making. We were very fortunate to have a patient family representative, a parent actually, of a child who underwent spinal fusion surgery on our team. And with that person, we were able to validate the process needs based on their experience. That person co-led the family surveys that were administered to other families to get more data, to understand more about family perception and assess quality of care and quality of post-operative outcomes. It has also helped improve the stakeholder buy-in and the strategies for implementation, because when stakeholders realized that there was a parent involved, they actually were really interested to be involved. So our circle of stakeholders grew with time, and we ended up working now with chief anesthesiologists of the hospital, for instance. And that person also connected the team to an online parent network to reinforce patient engagement. There's something called the Courageous Parent Network. Not to make any promotion, but this is something of, I think, humanitarian value. So this person really put us on that platform so that we can even spread our awareness of what we are understanding of the perioperative care for kids undergoing spinal fusion surgery. So I believe that our patient engagement has been happening on the two levels, on the direct care and on the organizational design and governance at different levels of continuum through consultation, involvement, and partnership and leadership. So what are the takeaways and learnings from this design approach with families? We've learned that the perioperative care is complex and segmented for medically complex children. And we know now that we have to identify high-risk patients early on, and that the early intervention of primary and complex care is very important to improve the coordination among providers. And family awareness of the entire process alleviates these coordination mishaps. And the involvement of patients and families throughout this project has really helped us engage in those methods, the cross-functional maps, the FMEA, the contrast analysis, and the other basic tools, but less so in the more complex tools, such as the functional resonance analysis method and SEEPs. We found that there is a meaningful role for patients and family engagement that is even easier than we imagined. And their experiences are really vital to the process redesign. Oops. But we have some we have some challenges and strategies. So quickly, there's limited availability to have patients involved. Time to complete the systems engineering methods, we didn't have enough time. Data collection was hard, and spreading the design thinking to patients and patient outreach is hard. But we've decided to put more work. We stepped into the grounds of the hospital, not only worked in our silos, and we've made further dyads. And I guess having weekly calls with the parent was good enough to lead this patient engagement initiative. So thank you. I'm going to hand it over back to Professor Daniel.
Thank you, Joseph and Annie and Katie. So speaking of limited time, so there's some insight into three specific projects, and I'd like to talk about the bigger picture, and then we can have a couple of minutes of Q&A, and then we'll transition quickly because there's not that much time. While I'm talking, you're looking at the workflow of another learning lab, which is very IT focused. So some of the methods being used across the life cycle are human factors and usability analysis, but it's also involved a large-scale computer model of a system of systems simulating how patients flow through patient portals, allowing them to engage in managing their own safety as they go through healthcare, as they go through a length of stay. And there's some pretty interesting work. So the bigger picture is what are we learning? Right? So we're throwing, and there's 11 other learning labs, throwing a lot of different methodology, some proven, some known, some less known. We started with sort of an exhaustive exploration of what's new. And I had a fellow visiting, international fellow, who's very steeped in this emerging body of knowledge called Safety 2. And we did a rapid study of all of the thoughts and methods in complex systems and Safety 2 and so on. And for us, like Annie talked about SEEPs, most of the papers coming out about new methods that are highly effective in tackling safety are authored by the inventors of them, right? And so they may be quite useful, but there may be some sort of publication bias in this. We're pretty agnostic. We care about safety. And so we're quite interested in how much time do these methods take? Are they really effective robustly across health systems? Are they easy to glom onto for us, for healthcare systems? Are they too sort of abstract? What can we learn about these methods? And if they're not effective, are we doing enough work that we know is effective so that at least these willing pilots that their systems will get better. So it's been pretty interesting. You can see a list. We're trying to call this out. What are we learning about methods? What are we learning about the problems? And incredibly importantly, it's a little bit of a platitude. What are we learning about trying to work together? Right? Because we're different species sometimes. And just to give you a little look at that, we just had a focus group in one of the learning labs with some questions. And we started with, okay, all of you clinicians and folks in the health systems, we've been cohabitating for 3.5 years now. How would you define systems engineering? How would you define human factors? Can you describe some